This question deals with a 43-year-old Caucasian male with hematuria and hypertension, undergoes a kidney biopsy. The immunofluorescent microscopy findings are shown on the slide below. So we see a 43-year-old male with hematuria, so that's our first finding, hematuria and hypertension, okay? I wish we could do this in the exam, take our time to really break it down. I wish we had the time for it, but at least we can learn like this. So he had hematuria and hypertension and undergoes a kidney biopsy. And the biopsy shows that the immunofluorescent microscopy findings are shown on the slide below. And we can see immunofluorescent findings, okay? Under immunofluorescent, I can see that there is a very uniform type of, uniform deposition of antibodies. I can see uniform deposition of antibodies. Okay, this is what I found on immunofluorescent. Now the question says, which of the following would be the most likely light microscopy finding in this patient? So what are we going to find in light microscopy? So for LM is light microscopy, IF is immunofluorescent. And I'm sure you know that. I just wanted to, just in case. So what is this? The patient has hematuria and hypertension, okay, and he has a uniform deposition of antibodies. That is the biggest clue. Whenever you have uniform deposition of antibodies, that screams to me that that's good pasture, okay? So with good pasture, what kind of kidney manifestation do we see with good pasture? We see RPGN, okay? RPGN, good pasture gives rise to RPGN in the kidney, and RPGN gives rise to what do we see on light microscopy on RPGN? The one thing that we all know that we see in light microscopy is going to be crescents. Okay, it's clear. So that's what we see in light microscopy. We already found our answer. We didn't even have to look at the options. But let's talk about a little bit more on the whole crescent thing. What is really crescent made up of? Crescents are made up of a couple of things. Crescents are made up of mostly fibrin. Crescents are made up of parietal cell, right? Crescents are made up of monocytes. Crescents are made up of macrophages. Crescents are made up of plasma proteins, for example, IgG and C3b. These are what crescents are made up of, right? So those are the presentations for RPGN. So let's talk a little bit more about Good Pasture. What kind of other presentation do we see in Good Pasture? We see hemoptysis and hematuria. And why do we see hemoptysis? What is the main presentation of Good Pasture syndrome? What happens in Good Pasture is that there is going to be antibodies or anti-GBM antibody or glomerular basement membrane antibody. This antibody not only binds to the basement membrane of the glomerulus, it goes and binds to the basement membrane of the lungs, giving us lung problem as well. So that's why there is going to be hemoptysis and Good Pasture syndrome, which we always see in lungs. They attack the type 4 collagen. They attack the alpha 3 type 4 collagen of the basement membrane. Kind of important to remember. What kind of hypersensitivity is Good Pasture? Good Pasture is actually type 2 hypersensitivity, okay? And so that's about Good Pasture. Now let's talk about where else do we see crescents other than Good Pasture. We see crescents in, other than Good Pasture, we see it in Wagner. We see it in the other one, microscopic polyangiitis. All these are going to show crescents, okay? So just a general overview. So let's go through each and every option that we have. So option A says basement membrane splitting, okay? Basement membrane splitting, where do we see basement membrane splitting? We see it in Alport. That's one. We also see in MPGN. Both of them are going to show basement membrane splitting. With Alports, we're also going to see ocular problems. Okay, so they're going to be deaf and ocular problems. So deafness and ocular problem is going to be seen with Alport, and they're going to show basement membrane splitting. So for MPGN, what kind of thing are we going to see on light microscopy, and what kind of thing are we going to see on electron microscopy? On light microscopy, we are going to see that there is going to be mesangial growth. Okay, mesangial growth. This mesangial growth is responsible for the splitting, okay, because it grows kind of in between. And what about electron microscopy? In electron microscopy, we're going to see dense deposits. We're going to see dense deposits, okay? So that is our MPGN. So that was a little bit of discussion on the whole choice A. What about choice B? What is that? When do we see capillary wall thickening? So we see capillary wall thickening in MGN, okay? In MGN, light microscopy shows two, two, two thickening. One is capillary wall. Capillary wall will thicken, and the other thing that's going to thicken is going to be the glomerular basin membrane is also going to thicken. Okay, this is what we're going to see on light microscopy, but on electron microscopy we are going to see the spike and dome appearance. Spike and dome appearance is going to be seen on electron microscopy for MGN. What are some of the causes of MGN? SLE, solid tumors, anti-cancer drugs, anti-malarial drugs, drugs in general, hepatitis B, C, all those things then can cause MGN, which is going to cause capillary wall thickening, okay, and also thickening of the glomerular basement membrane. So that is going to be MGN. That is choice B. What about choice C? Focal granular sclerosis. Focal granular. Focal granular sclerosis. Where do we see this one? That's the obvious one. We see focal granular sclerosis in focal segmental. Focal segmental, what are some of the common causes of focal segmental? HIV is one of the common causes of focal segmental, right? HIV causes focal segmental. We're going to see IgM and C3 deposition. IgM, not IgG. IgM deposition on C3 on focal sclerosis. Those are the sclerotic areas of the glomeruli.